Hello and welcome to EAO's monthly Just Ask session. It's a fantastic opportunity for you to ask your questions to an industry expert throughout an hour-long session here live on YouTube. Now, firstly, where are you tuning in from tonight? I'm very curious to know. This is a very international session, and we'd really like to know where you're tuning in from and where you're listening to today. Please share it in the chat on the right hand of the screen. Now, of course, Just Ask is a fantastic opportunity for you to ask your questions with an expert, as I just said. So please take this opportunity to ask any questions that you have to today's guests. So tonight, Dr. Stavros Pelekanos, who holds a doctoral degree in prosthodontics and was appointed a full-time lecturer at the Department of Prosthodontics Dental School at the University of Athens, Greece, is with us here live. Now, he's established a private practice in Athens, oriented towards prosthodontics, implantology, and aesthetic dentistry. To date, he has published over 20 articles in peer-reviewed journals and 3 chapters in books, and he's an active member of the European Academy of Aesthetic Dentistry. Firstly, thank you so much for being with us here this evening, Stavros. How are you doing?
Hi, Hayley. Good evening, everybody, or good morning, wherever you are listening from. I'm doing fine, actually. I'm really looking forward to our discussion. I hope we will have a lot of questions and to have a nice evening.
Absolutely. So just to give a little background on the title of today's session, it's the concept of one abutment, one time myth or clinical reality. Now, Stavros, just to kind of get a bit of background with regards to this, why are you such a proponent of this technique, and why is it something you've invested so much time in developing?
Yes, it's actually something that I have been doing for many, many years. The first time I used this technique was 2005. So actually, we all know that this is like the success is a multifactorial procedure. So I think this is like a small stone in the whole mosaic. So it's going to be really interesting to talk about it.
And we can't wait to hear what you have to say about it. So maybe you just give us a brief introduction to what you'll be discussing today, maybe a bit more detail.
Yes. So let me share my screen. Is it, can you see my screen?
Yes, we can.
Great. So actually, timing is really very important, not only in dentistry, but also in our life. So the question is always when and how. So in implantology, I would say we have 4 timing for implant placement. We can go immediate, early, delayed, or late. This is type 1, type 2, type 3, type 4. Regarding bone, we can place the bone before implant placement or during implant placement. Connective tissue graft, which is almost all the time something that we need in aesthetic implant dentistry. We can do before implant, like a socket preservation, during implant or after implant placement at second stage. And last but not least, which is our topic for today, abutment placement. We can do it immediate, one time. We can do it again one time at the second stage, but or we can go delayed, where we have multiple disconnections. So actually, the first guy who talked about it was this guy here from Sweden, Abramson, 1997. I was a student when I read this article, when he stated that repeated placement and removal of abutments could lead to bone resorption and apical displacement of the soft tissue. Since then, many people try to have published on it, animal studies, human studies. We have seen controversial results. One of them is this one from Brezan, showing that in the group of 4 disconnections, we have 0.43 bone loss. So some people would ask, is this really clinically relevant? I mean, that we lose a little bit of bone when we change the abutment more times. But like I said, it's a small stone in the mosaic. It's a multifactorial procedure. And it doesn't apply for every implant system, I would say. I mean, you see on the left side of my screen, this is an external connection implant, which is a typical Brennemark implant, an internal connection in the middle, or a soft tissue level implant. This technique does not apply for every implant system. And starting with an old case, left central incisor has to be extracted more than 10 years ago. At that time, already we used the full guided procedure, as you can see here. And on the right side of the screen, we can see that I have placed a full contour zirconia abutment. So full contour zirconia abutment, which we have already fabricated before we touch the patient. And on top of that, we did a crown, Empress, I think, crown. And the result was quite stable. This was 11 years ago, and this was 11 years after. So this is like a couple of months ago, where we, as you can see here, the neighboring tooth moved a little bit coronally, but more or less, the situation is really stable. An old case where we did one-time abutment, and a small video showing a stable result after 10 years. So we have published this already 10 years ago, together with Sasha Jovanovic and Thanos Dounis and Egon Oive, as a definitive abutment-driven second-stage surgery. But now the question is, the difficulty here was that we have to fabricate the abutment as a full contour. So actually, this was like not so easy. And we had to cement. And we all know that when we cement, it's really difficult to get the cement rest out of it. So we try to figure out another way of one-time abutment, which might be not as a full contour. So, and in this image, you see an implant with an intermediate one-time abutment. So basically what you can see here is not the implant head, but is one-time intermediate abutment. And defining the three zones of the transmucosal contour. And how do we define the three zones? The three zones, and this is an article that is going to be published next month in the International Journal of Periodontics and Restorative Dentistry. We did it together with my friend Yannis Vergoulis. So the deep zone is 1.5 millimeter and corresponds to the connective tissue. Transitional zone is 1.5, which corresponds to the junctional epithelium. And the cervical zone is 1 millimeter. So what we do and we want to use and we want to stabilize is the deep zone. So this is where we use actually the one-time abutment, not as a full contour, but just like an intermediate abutment, which is on the deep zone.
And I'm presuming you're using the same connections in each intervention, right?
Yes, actually, when we started, we used the flat-to-flat connections. You're talking about implant connections, right?
Yeah.
Yes. So we moved from flat-to-flat connections. Implantology moved to more stable connections, and these connections are, let's say, the internal connections. And for me, it's really very important to. This technique works for implant systems that have a good, steep, stable internal connection. That's why when I started the talk, I said it's not for every implant system. Like here, for example, you see in the middle that the implant is placed a little bit deeper, right? So placing the implant deeper and using the one abutment, one-time protocol is really beneficial. And let's say it gives us the versatility of the system to play with the abutment. Sometimes we use 1.5, sometimes we use 2, 3, or 4 millimeter. I'm gonna show you some cases later on. But if you have a soft tissue level implant, for example, which is on the right side here, there is no need to use an one-time abutment.
So I have a question from Maxime Bedu, who says, does that mean it's only for thick gingiva types?
No, no, it's for every phenotype or gingival type. And as you will see a little bit later on, it helps if we place the implant deeper, it helps that we are, let's say, enhancing the width of the soft tissue. So basically, we are improving the phenotype of the soft tissue. And last but not least, we know from many people, like from Chen or from Pablo Galindo Moreno, that having an abutment which is 1.5 or 2 millimeters is really beneficial for the bone resorption. So the next zone is a transitional zone, actually, where we have 3 different scenarios. One is to make it concave, second, straight, or convex. So when we have like you said, the thick tissue phenotype, then where we need to reconstruct or maintain, then we can use a convex or a straight, let's say, approach. But when we have a thin tissue phenotype or an immediate site where we need to enhance the soft tissue, like to put a connective tissue graft or bone graft, as you can see on immediate implant placement, then we use the one-time abutment together with a concave transitional zone. So this is really beneficial to enhance. It's like making a vertical preparation on a tooth to enhance and to increase the width and the amount of the connective tissue. And then after the wound healing, we can go like straight or convex according to the case. I hope that was clear answer to my friend.
I have another question from Katerina, who says, why not use a transmucosal implant with straight or convergent neck, avoiding a screw on top of a screw?
Can you repeat the question? I didn't.
Why not use a transmucosal implant with straight or convergent neck, avoiding a screw on top of a screw?
Excellent question. So practically, why we don't use a soft tissue level implant? The answer is pretty clear for me because, as I said, sometimes the implant is like 3.5 or 4 millimeter below the clinical crown. Sometimes is at 4.5 or 5 or even 5.5 or 6 millimeter below. So we need different transmucosal heights. And an implant combat is really difficult, almost impossible to produce an implant with different transmucosal heights. So practically, the best way is to use the one-time abutment protocol with the appropriate height. So I can choose between 1.5 or 2 or 2.5 or 3 millimeter abutment and be more versatile according to the case. So I hope that was clear. And also in proximal profiles, when we we know that we especially in the single implants in the aesthetic zone where we have a high scalloping, is really very important to keep the distance of 1.5, sometimes 2 millimeter from the bone. So it's really helpful when we use the one-time abutment and we don't disconnect exactly this very, very sensitive area, where is the neck of the implant. So basically we are using we call it the connect abutment that you see on the left side of the screen, which is comparing to the multi-unit abutment, which is on the right side of the screen, which is an internal connection, is really very stable, and we use it one time. So basically, if I am allowed to show this very nice image from my friend David Nore from Belgium, is like a 12-degree internal connection, 2 millimeter long, one time, and basically we seal the implant. So it's like transforming a bone level implant into a soft tissue level implant. So this is the idea behind it. We published this together with Irini Palanza, but also others have published on this issue. And this is like two centrals comparing, like on the right side, a multi-unit, and on the left side, an internal connect abutment. If you see the radiograph more closely, in here you can see that on the right side of the screen, we can really place, if we need, an implant deeper. And this is the versatility of the protocol. So basically, if we need, we can place the implant a little bit deeper. And we follow this case since 6 years now. More than six.
But would the placement, this placement have any effect on the maybe kind of any marginal bone loss or any soft tissue damage at all?
No, actually, like I said, if you have a good conical connection, a steep good conical connection, and you don't disconnect this abutment, there is not only there is absolutely no harm, there is protection for the bone. So, like the protocol, I would say we use this protocol for two kinds of procedure. First, for immediate, which more and more people are using this concept. Let's say for an immediate implant placement, we place the implant, we have the full buccal bony contour, we place xenograft in front of the implant to the bone. Then we place the one-time abutment. Then we use allograft, which is in contact with the abutment. We used to use at the beginning only xenograft, but xenograft is an excellent material, but we had oftentimes this popcorn effect coming out. So and then we started to use the xenograft more to the implant side and the allograft to the one-time connect abutment. Then we have like three scenarios. The first scenario is we have a good stability, more than 30 Newton, and then we go for an immediate loading or immediate provisionalization, plus a soft tissue graft, a connective tissue graft, which we use always because we know that we have, whatever we do, we will have some resorption of the bony reeds of the facial plate. Second scenario, if we don't have the 30 Newton, but we have more than 15, we do exactly the same, but we don't provisionalize the implant. We just put a customized healing abutment. And third option is that we have like less than 15 degrees, and then we cover the implant. But always using the one-time abutment. Even if I cover the implant, I'm using the one-time abutment as a tending, let's say, device in order to have more soft tissue afterwards. So this is the protocol that we are using when we use the one-time intermediate connect abutment.
We have a question from Serdar Gosku. What do you think tissue level dental implants? What do you think of tissue level dental implants?
I think actually the best implant would be tissue level. I totally agree. But as I said, the question is, first of all, the height of the tissue level, which sometimes can vary, especially when we have like a scalloping bony profile. We might need a little bit longer neck or a little bit shorter neck. And second, which I really love, is the the platform switching concept, which it can be provided with this concept. So it's actually the same question like we had before. So let me show you a case just to show you how we utilize this one-time abutment. We have a horizontal root fracture here, number 21. So every time we do something, we plan before. And here you see the implant is planned to be 4.5 millimeters below the clinical crown. Then we plan always the abutment. This is the one-time abutment, intermediate abutment, which is 2 millimeters in height. Then we do the surgery, we extract the tooth. In this case, we use the socket seal technique. I am sure you are familiar with it. Marcus Hirschler was the first guy who utilized this technique. I always go navigated for implant placement, which means even I have placed thousands of implants in my life, but the security and the quality of my dental life that navigation is giving is really amazing. It's like using Google Maps. Huh?
It's second to none.
everybody uses Google Maps, no?
Right.
So again, on the left side, some very important steps is the socket shield. If we don't have the socket shield, we always place a connective tissue graft, navigation, and concave profile. So basically, the one-time abutment is protecting the shield, the implant head, and let's say the coronal part of the implant head, which is the most important. And this is like 3 months after implant placement. You see the crown is a little bit shorter because we didn't want to load it. And we use the same fracture tooth of the patient. We took the same tooth and we put it back, but on the implant. So, yes.
Sorry, just a question from Maxime Bedu.
Yes.
For the healing abutment, you seem to make it, correct? Which
yes.
materials are you using?
Yes, we are using like a normal PMMA material if we mill it, or any material which is like a composite material, because we work not on the deep zone, we work on the transitional zone, which is like we don't work close to the implant head. So whatever material you use, you can use.
Okay, thank you.
So, and basically this is what we see after 3 months, a very stable situation. And this is the one-time abutment, which if you take the probe and you go inside, it's impossible to probe. Why? Because we have dense connective tissue around this abutment. So we know that on top of the bone, there is always connective tissue. And this is what we are trying to do. Like we are trying to maintain the connective tissue above the bone with this technique by using a bone level implant with a good connection and one-time abutment, which we never remove anymore. So we form the deep zone of the emergence profile. So this is really very important in this protocol. And at the end, we have a nice crown, of course. This guy had a second accident a year later. And as you see, there are some cracks.
It's fractured toe teeth now, to both of them.
Exactly.
At least they match.
And you know what? Then Nondas, my dental technician, needed to do a really, and I told him, listen, we can do a veneer, like not to have the cracks, or we can do again the crown on the implant. And he decided to do the crown of the implant, and like, look at this, Nondas did a fantastic job. I mean, You cannot recognize which tooth is the implant and which tooth is the normal tooth of the patient. Anyway, another important thing for this technique is not only for immediates, it's also for the late approach. So this is something that I really love for non-immediate sites, the disc punch graft, where we use like a 4 millimeter connect together with the connective tissue graft, where we punch it, we make a hole, with or without membrane if we need to do sometimes contour augmentation. And I'm going to show you exactly like a case here, which is much more difficult than the case before, because the tooth here is missing since, I don't know, 2-3 years. And the patient came to me like this, so with a missing tooth and a removable denture. Of course, every time we see the patient, we do a digital smile design. We use the smile cloud. We are showing to the patient the future smile. And of course, the case acceptance is really like high when we can show him in his face what we have to do. And he's also participating in choosing his smile. So it's really nice thing to do. And of course, here we can see that the midline needs to be shifted, that he needs some ortho, because the space that he had was really like large, 9 millimeters. So we need to reduce. But the most important thing is that we know from before we touch the patient that if we place the implant in the correct position, some threads of the implant will be out of the bone. So here the implant is 4.5 millimeter below the clinical crown, and we plan everything. And this is the technique that we are using together with a one-time abutment. So we punch the membrane and we make also a small, this is a resorbable membrane, a small hole on the connective tissue graft, as you can see here. And the whole thing, we bring it onto the implant with the one-time abutment. And the one-time abutment is a 4 millimeter connect abutment. So this is like everything in one shot.
Yeah.
Like a big surgery. Otherwise, we needed to do like 2 or 3 surgeries to do the case. So now like we have in one shot, like the contour augmentation where we can like put some bone to the place where the bone was missing, practically over the first 3-4 threads of the implant. And at the same time, here is the bone, at the same time, enhancing the soft tissue of the patient. So we do, let's say, 2 miracles in one time. And here you can see the use of the one-time abutment. Exactly, which is holding in place the soft tissue, as you can see here. The soft tissue is here through the connect abutment. So basically we have one-time abutment, connective tissue graft, plus the contour augmentation. And this is something that I really love to do. So, and with this technique, we have the soft tissue where we need it, which means we have the soft tissue exactly like on mesial and distal of the tooth, on the papilla side, and buccally.
Stavros, I have a lot of questions for you.
Yes.
Everyone is really participating tonight, which is great to see. Continue asking your questions, because this is the whole objective of the Just Ask session. So firstly, what kind of cement do you use for PMMA?
On the PMMA, we use any dual cure cement. So whatever, like Panavia or Multilink, whatever you want to use, you can use between the tie base and the PMMA.
What do you consider as a deep connection implant? I mean, enough for such a procedure. What length and what angulation of the cone? That's Maxime Bedou, who's asked another question.
Can you repeat the question again?
What do you consider as a deep connection implant?
Yes. So that's a good question. So when we're talking about internal connection, we can have like a flat-to-flat connection, and then we categorize two types of conical connection. The ones that are from let's say 20 degrees to 45 degrees each side, which is like let's say a wide connection, and the ones that are 12 degrees and less, like ankylose or Astra, if I'm allowed to say some names. So for me, the borderline of the friction fit is the 12 degrees. What do I mean by that? Friction fit is when we unscrew, let's say, an abutment, and we have to pull it to take it out. So if we need to pull it to take it out, then it means that we have some friction fit. So the borderline for the friction fit is the
12 degrees.
Yes, exactly.
To Mitchell Pierce, what systems are compatible with one-time abutment?
I think now there are I started the one-time abutment protocol with 3i, which was a flat-to-flat connection, and this protocol was, I did the first cases and we published this more than 15 years ago. The problem with this was that it was a two-screw procedure, so the abutment has a second screw. Then we continue with MIS, with the connect abutment of the V3. And then since then, I think quite a few companies, or now even more and more companies are let's say, taking the protocol like Nobel and with an on-one abutment or Anthogir, and there are more and more.
Okay. Victor Pallery, hello from Moldova. Hello. Victor, could you explain the changes in peri-implant marginal bone level associated with immediate use of definitive abutments? Could you explain the changes in peri-implant marginal bone level associated with immediate use of definitive abutments?
Actually, I don't really understand this question. The aim of the one-time abutment is actually to not to have bone loss, so to keep the bone at the implant level, and to form the deep zone to keep the connective tissue above the periosteum on the abutment. So this is the aim of the whole procedure. If we have bone loss, we are already in minus, we are already lost.
And Maxime, once again, you could have used a carrot technique instead of the membrane.
The what?
The carrot technique, kaori, instead of the membrane. Carrot? Yeah, it's called, he says carrot technique.
Yeah, so I'm not familiar with this one.
So we're not sure. Okay. And just one, I saw that, of course, you the age of your user case that you're just discussing right now is 40 years old. But how are there age considerations for this technique at all?
No, there is no age consideration. I mean, if you can place the implant to a patient, you can use this technique. I mean, okay. And of course, we are trying. If you ask me, to delay implant placement. So we are trying to keep the teeth first. So the later, the better.
Okay, thank you.
So basically, this technique is like holding the connective tissue with the abutment by placing the around like a pouch on the one-time abutment. So this is another case, like is showing this technique, and we call it the disc punch graft, which we are going to publish soon together with Egon Oive and Vency Stankov, where we punch the connective tissue and we bring the one-time abutment through the connective tissue with or without membrane. So this is like the protocol and the idea behind it. And if I can continue with the case, this is the case. Of course, we did some ortho, like we wait 6 months. And as you can see here, we placed a 4 millimeter connect abutment, which is like semi-submerged. And then what we do, we exchange the one-time abutment. So we can call it a two-time abutment. The 4 millimeter we exchanged with a 2 millimeter connect abutment in order to be able to form the transmucosal contour and the transitional zone. Here you can see the 4 millimeter abutment on the left side and the 2 millimeter abutment on the right side. And we provisionalized the case because this was a late implant placement. And we did some veneers in this case for this patient. Final impression. The final transmucosal contour and zone. Here you see the silicon index for the veneer preparation, and monolithic restorations with a slight layering. So at the end, what you see here is the, not the implant, again, the connect abutment, which is one time placed. And here you can see a nice view of it. After we cement it, we bonded the veneers, and before we deliver the final crown to the patient. So through the procedure, we see before, during the implant placement and the healing, the 4 millimeter connect abutment. And at the end, we have a 2 millimeter abutment with the zirconia crown on top.
Vladir has a question. Do you think the future of abutment is tie-base and zirconium CAD/CAM technology in order to copy the emergency profile?
Sorry, Hayley, again, can you repeat the question?
Do you think the future of abutment is tie-base and zirconium CAD/CAM technology in order to copy the emergency profile?
Yeah, actually, we use tie bases, that's for sure, but we use the tie bases on top of the one-time abutment. So, and of course, the material of choice is zirconium. There is no doubt that titanium and zirconia are the two materials that are proven to be biocompatible, and these are the material of choice in any of my cases.
Okay, just writing that down. Is there a difference in incidence of prosthesis complications, such as screw loosening, between one-time abutment and conventional screwed definitive prostheses?
It's a very good question. Very good question. I can talk from my experience. I have done hundreds, if not thousands of cases, and I didn't even have one screw loosening. So we are talking about the second screw, because the first screw, the abutment, is the first screw, which is one abutment, one piece. We're talking about the second screw. I never had a screw loosening on the structure on top of it.
Maxime, once again, how do you punch the soft tissue graft, which you mentioned earlier?
Yes, I mean, there is a small instrument. If I can go here, you see a small instrument where we do a small punch here, but you can do it also with your scalpel.
Okay. how much NCM do you need to screw the one-time abutment?
Yes, the one-time abutment in this connection type of connection, we use 30 Newton per centimeter. So always before we take an impression or when we place the implant or at the second stage, we final torque the abutment at 30 Newton.
30 Newton, okay. What is your opinion in no abutment prosthetics like matrix implant?
I think it's a very promising, of course, the best abutment is no abutment, that's for sure. So I think the future in implant dentistry should go in this direction where we will eliminate the tie basis. And I totally agree that if we manage to find a connection which is going directly onto the implant, which can be soft tissue level, this is the way to go. But there is a lot of research and clinical research to be done on this topic, but it's for sure the way to go.
Okay. And Jacques wants to know, what do you think about using an iPhysio provisional abutment to prevent multiple aggressions of the critical gingival deep contour?
The iPhysio, if I am not mistaken, is like a customized or prefabricated emergence profile. So basically, whatever you can use on top of the abutment is, I mean, you can use. You can use the iPhysio, you can use the cervical system, whatever system you have in your armamentarium, or you can prefabricate already abutments. This is something that you can use anytime.
Okay. Okay, that's all our questions for the moment. But if you do have any more questions, please don't hesitate in asking them, of course, to our guest this evening, Stavros. So Stavros, if you can continue with your user case, perfect.
Yes, we use this technique not only for the aesthetic zone, but we can use it also for the posterior zones. And here you can see like a case where we extracted the second premolar and the first molar. We try to go immediate if we can. So we planned this case and we went for immediate implant placement at the molar site and a late implant placement at the first premolar site. And as you can see here, there is always the bone when we are working in the mouth of the patient. It's never like a table. It's always with a scallop, some bone a little bit higher, some bone a little bit lower. So in none of the cases I like to remove bone. So what I do is placing the implant a little bit deeper, using the the one-time abutment, as you will see here. So we use the standard connect on the premolar side and the wide connect on the molar side, which we never remove anymore. So practically extractions, implant placement, one-time abutment, standard and wide connect. And at the same time, we take the impression. So basically, we do everything in the first appointment. So after 3 months, we have everything ready. Actually, we can deliver the final prosthesis. I think quality of life, we have already a stressful job to do. I mean, to be a dentist is really stressful. So quality of life, what is quality of life? To spend less time on the chair with the patient. I rather be with my friends or my colleagues and talk together or having a coffee and talking about the case than working. So actually, I saw this patient only 3 times. First time was a consultation, second time was the surgery, and third time was the delivery.
And it's less stressful for the patient as well to know they don't have to systematically keep on coming back.
Of course, if I go back, this was the first time I saw the patient is when I extracted his tooth. Actually, the first time I worked on the patient, not I saw, I worked. The first time I worked on a patient was this one, this appointment, and then taking the impression already at the first appointment, and this is already the last time, the third one, when I deliver the final prosthesis, which of course is a monolithic zirconia. We don't layer in the posterior. Hand polish, we know very well from studies from Thomas Linkevicius that we need really to high polish the zirconia, which occupies the transitional zone, actually, where we want to have like a stable epithelium, if I am allowed to say this way, and we glaze and stain only what is outside of the transitional zone. And yeah, this is it. I mean, we deliver the final prosthesis after 3 appointments.
You mentioned earlier one complication could be the cement, but I mean, are there any other, why wouldn't a dentist use this technique? What would maybe clinically prevent him from doing so?
Yes, that's a good question, Hayley. Actually, as I mentioned at the beginning, the first attempts to do this technique was to put the final abutment immediately one time, and then to cement, because we didn't deliver the final prosthesis at the time of implant placement. So basically, we put the final abutment one contour and we cement it. So cementing, we know it's not the best way to go in implantology because it's extremely difficult, if not impossible, to take the cement rest out of it. I still have old cases where I see cement rest after years. And these are my cases. So basically, I was not able to remove the cement I put on the implant abutment. So basically, I hate to cement. So this is something that let's say, a drawback for the one-time full contour abutment. Second contraindication could be if your implant system does not provide you the correct intermediate abutment or abutment to do so. So other than that, I don't see really any other, problem with the technique.
Okay. And of course, it's saving time as well. So it's you can have more time drinking coffee with your colleagues and discussing the cases rather than having the patient in the dentist chair.
Yeah. So basically, we can use this technique actually also when we have like we cover our implants, and for some reason we don't place any abutment, and we do the second stage surgery. So this is like just a simple case where we have 2 implants which are covered, and we always measure the soft tissue that we have above our implants. So you see on the left side is like 4 millimeter, on the right side is 3.5, and then we choose the one-time abutment. So it's like something which is really versatile, and you can see here that we used here the one. We still have 2 millimeters to play with the emergence profile. So basically, we make a small cut, incision, we open the soft tissue, we place the one-time abutment, intermediate abutment, and this is the first time that we see the bone, or the second, because it's a second stage surgery. So we place the abutment, which is 1.5. You see again, I choose 1.5 because I have 3.5 or 4. And here you can see that the bone is on top of the abutment, right? And not on top, in contact with the abutment. This doesn't mean that the bone will stay there. Don't get me wrong. This is like the future deep zone of my implant. I know that this bone will disappear, but in the place of this bone will come the connective tissue. So basically, I am forming the deep zone of my emergence profile. And I still have another 2 millimeters to, let's say, play with the emergence profile with the transmucosal contour. And like I said before, here you can use the cervical system. This is a system which I love to use by VPI, where we can like customize the emergence profile of the implants. And here you can see it's practically like transforming a bone level implant into a soft tissue level implant by using the one abutment, one time concept. And just a small video to show the two implants where we place the one-time abutment at the second stage surgery. So, is there any other question?
There are, yes. So Maxime wants to know once again, this technique is only possible when fully guided.
No. No. This technique is possible for any technique that you are using. It doesn't mean that you need to be fully guided, but when we are guided, we are really in the safe side of the in the safe side of the procedure.
You mentioned the disc punch graft technique earlier on. Where can people find out more about this?
Wait for our publication. So
where can we find out about it?
So yeah, actually the punch graft technique is something that actually it's not like a similar approach is done by Inaki Gaborena from Spain. With he is using the slim abutment. The difference between the Gaborena's technique and our technique is that Inaki has to connect and disconnect like a few times the abutment, and we use the one-time abutment technique. So, or just one disconnection. So there is nothing written yet for this technique, but we are on it.
You're developing it. Good
Yes.
to hear. Well, so keep your eyes open for the literature on that I'm sure will be published, hopefully, very soon. Well, I think that's enough with, I think that was our last question of the evening, Stavros. It's been a very interactive session we've had here. Lots of interaction from the people watching, which is, of course, great to see. As I said, it's a take-home message. Here we go. Yeah, which is, of course, the objective of Just Ask. So what is your take-home message, Stavros?
Yeah, I would say the take-home message for the one-time abutment protocol, the way we use it, is that the one abutment one-time protocol seems to be beneficial for hard and soft tissue stabilities. There are more and more publications coming out for showing small numbers of improvements, let's say some tenths of the millimeter, again, could be in one publication, could be statistically significant, in others not. But again, it's a small stone in the mosaic. So the one-time intermediate connect abutment makes sense as I described to you, when used for bone level implants with good steep conical connection. So for me, this is very important to use this technique. As we discussed, the full contour requires experience. We do it sometimes when we have a full contour, immediate one-time abutment, and can be used in selected cases with caution, and I would say in grafted cases, not in cases that we graft at the same time. And the last, I would say, take-home message is that the narrow intermediate one-time abutments can be used also as tending abutments, one time stabilizing the membranes if we need like to do a contour augmentation, and most importantly, to place a soft tissue graft vertically and interproximally where we really need it.
Thank you for those conclusive takeaways. Now we do have a question just before I have a final word on what's up and coming. So Katerina wants to know, if the implant goes in deeper than planned, would the one-time abutment allow bone formation on its surface?
No. If the implant goes deeper, if I'm allowed to show this image here, if the implant goes deeper, it doesn't matter that it doesn't mean that the bone will stay on the abutment. What will change if an implant is going deeper, what will change is not the deep zone, because the deep zone and the connective tissue will always be 1.5. The Mother Nature gave us these numbers between 1, 1.2, 1.5. This we cannot change. What will change is the transitional zone. So basically, we can have a transitional zone which is more than 1.5. So if I go to the next slide here, in the middle, it doesn't mean that the bone will stay here where my sensor is. This means that the transitional zone, the deep zone will be 1.5, and the rest of the abutment, which is like a 3 or 4 millimeter abutment, will occupy the space of the transitional zone, which will be a little bit higher. To hold the bone on a titanium surface, it needs to be rough. Okay, well, that answers your questions, Katerina. And just a closing word from Vladimir Muglia. Congratulations, Stavros. The one-time abutment feature allows the clinician to prevent from the disconnection of the abutment in the biological area. So, which leads me to... That's correct. Well, thank you so much for this. Thank you so much for your time, for taking us through all your user cases this evening, your explanations. And if you are like Stavros, partial to literature, and you would like to showcase your clinical and scientific research, there are 10 days left to go to submit your extract for the EAO-DGI joint meeting, which will be held in Berlin from September the 28th until the 30th. Now, the link to submit it and get more information is in the description below this video. And don't forget, of course, the deadline is April the 13th. And of course, the committee will select the best submissions. They'll also be published in our official magazine, the COIR, the Clinical Oral Implant Research. That concludes this Just Ask session with Stavros Pelekanos. Thank you so much for your time once again. Thank you for sharing your insights. And have a great evening, morning, from wherever you're tuned in, all around the world. And hopefully see you next month. So thank you very much, Stavros. Take care. Thank you, Hayley. Take care. Bye-bye. Goodbye. Take care.